Good afternoon to my respected teachers and the faculties. We are already running late and so some hiccups are over there. Yeah, so let's start with the topic which is quite complicated as the disease of COVID itself. So I will, for the next 10 minutes, I will share the screen with you. Rather than a patient, I will present the fact. A post-COVID patient with recurrent palpitation. So what to conclude from this slide, so the patient's history is not clear even to me, but I will present the case to the panels for the further discussion if the time permits. In early March of 21, a 62-year-old male patient reports to our fever clinic with mild cough and malaise. Keeping in mind of ongoing pandemic, he had a nasopharyngeal swab which returned negative for the SARS-CoV-2 PCR. And he was treated symptomatically with antibiotics and anti-allergics in form of cetirizine and said to visit if something happens. On the day 3, he woke up in the morning with palpitations and a dyspnea on exertion. Temperature was around 100 degrees Fahrenheit, and also he is saying that he has a persistent cough for the last 24 hours, which is gradually occurring. He returns to our clinic, X-ray performed, which showed bilateral mild fluffy opacities with a peripheral saturation of 96%. A repeat SARS-CoV nasopharyngeal swab was repeated and it returned positive after 36 hours. At the time, his heart rate was 130 to 150 and an ECG showed, which I'm going to show you later, about 130 at the when it was documented. And the blood pressure was 180 by 100 mm of mercury. He was a known hypertensive for the last 10 years on amlodipine, and there was no known cardiac ailments, and perhaps he was also a good swimmer even at his age. So we can presume that he was in good of his health, and due to his old age and extreme tachycardia, he was admitted and started the standard operating procedure, and rate limiting metoprolol 50 mg has been provided in 2 divided doses. He settled with the standard treatment and made an uneventful recovery at day 9. He is a non-hypertensive, as I have told before, with a stable amlodipine for the last 10 years without any non-cardiac ailments. It was the ECG was documented at the time of his visit with short simple sinus tachycardia. After 2 weeks of discharge, he returns in post-COVID clinic with an on-off palpitation. Continued tachycardia was noted with a standing heart rate of around 100 per minute, fatigue and exercise intolerance, along with the subjective anorexia and insomnia, which was not prevalent beforehand. His seated resting blood pressure noted to be 156 by 100 mm of Hg, and his home blood pressure monitoring also showed a wide variation at the 2 or 3 readings in a day. He developed orthostatic high lightheadedness and P-syndrome. He returned to the emergency department after 3 days for evaluation, where his seated BP was 156 by 100 mm of Hg, heart rate was 125 BPM, and standing falls to 120 by 78 mm. A significant postural hypotension noted at that visit. He was observed for 2 hours and discharged with glucocortisone along with alprazolam 0.5 mg due to the non-availability of the bed and the triaging at that peak time. His resting ECG 2 days before of that event on the outside was absolutely normal. And this was it. On his last follow-up, he still complains of episodic lightheadedness, persistent fatigue, exercise intolerance, on-off palpitations to a lesser extent, but it's not subsided. He was advised for an autonomic workup, which is not available here, and a 24-hour Holter. His 2D echo was unremarkable with only grade 1 diastolic dysfunction. And this was also a ECG which was taken at the time of his admission by the in the COVID ward. It was showing the frequent ectopics. So what happens to him? This is a very short data and very short scenario to conclude or draw any diagnosis over there. So in our mind, there are some possibilities which can be given as a differential diagnosis. So a post-COVID patient in his 62 years of age without prior much complications, uneven recovery from the COVID with a standard treatment and on-off palpitations, and also there is a fluctuation of the blood pressure and to some extent autonomic symptoms. So our diagnosis at that time was inappropriate sinus tachycardia. It is quite IST is itself a terms, which is yet to be proved very definitely, like the COVID palpitation itself. The second is a very fun diagnosis, that is a panic attack. I think this is the most important thing which you find in the palpitations in a COVID patient, even during their treatment or after treatment. And the third is quite difficult to establish, even in the 2 to 3 months follow-up, to stampede a postural tachycardia syndrome after COVID-19. There are few case reports of this happen where the plenty of tests, particularly the adrenergic drive and also other tilt-table tests and the pseudomotor reflexes had been done. But unfortunately, I or we as a team cannot do it in this scenario. So this is also a possibility or probability which should be kept in mind, and probably the most important diagnosis. And the number 4, what else? Is it a prevalence, previous cardiac problem or some kind of arrhythmia which is gone unnerved after this event? So arrhythmias associated with COVID-19, like all these things, there are some reports that there is a plenty of arrhythmia cases in the China, but the data, the multiple analysis and of the randomized control analysis and the review articles show there is no much significant difference. But arrhythmias no have specific characteristics, but rather the same characteristic which a much more prevalent way, mostly due to the drug effects rather than the disease itself, further needs to control. So atrial arrhythmias, ventricular arrhythmias, VT storms, atrioventricular block when is affect the AV nodes, and this POST, which was a provisional diagnosis beforehand, cardiac arrhythmias during and after recovery, and the subclinical myocarditis due to the disease itself or due to the other causes of the drugs, inappropriate sinus tachycardia due to the uneven sinus node activation, monitoring of the corrected QT interval for the drugs like the hydroxychloroquine and the ritonavir earlier uses, that may be a cause. Unfortunately or fortunately, we haven't used this kind of drugs to this patient, so we can exclude these things. So the high incidence of the arrhythmias in COVID-19 is thought to be multifactorial, like the hypoxemia due to the ERDS itself, acute decline in the cardiac hemodynamics, myocarditis as a complication of any viral diseases, cardiac injury, prominent inflammatory response, direct viral infection to the ACE inhibitors, and the use of the QT prolonging medications. We should remember that all these things and all these observations came from the previous culprit, that is the SARS itself, rather than the SARS-CoV-2. This SARS and the SARS-CoV-2 has a 80% similarity homology. So we can presume from the SARS study that these multifactorial effects are the similar with the present SARS-CoV-2 or the COVID-2 epidemics or pandemics. So early reports from the Wuhan showed 44% of the patients admitted to their intensive care unit with the COVID-19 had arrhythmias, raising the initial suspicions of arrhythmias related to the COVID-19. But these people and these observations was lack of the concluding there was no reciprocal or the control trial, and there were multiple medications at that time. So it's quite difficult to say it is the disease itself or the drugs that is causing this arrhythmia. So all these things are copy pasted from the books, which are the similar like atrial fibrillation, superior ventricular tachycardia, PT, VF. All these have the same pathosymptoms and clinical findings: palpitation, dizziness, chest comfort, fatigue, thromboembolism, heart failure. COVID itself a thromboembolic disease with much prevalence to involve the lungs, and secondly the heart. And the block when prevalence is called the same like the faintings and dizziness, fatigue, all these things, and it is unclear whether it is reversible or irreversible at this present scenario. And QTC prolongation is mostly probably due to the electrolyte imbalances and the QT prolonging medication, and sometimes presumed due to the myocardial injury due to the epicardial vessels thrombosis. So the management of the cardiac arrhythmias in patients without COVID-19 infection, when it comes to the atrial tachyarrhythmias, are more or less similar with the original management of the tachycardia. Only difference that is said by the European Society of the Cardiology that we should not go for the direct intervention, at least up to when it is possible. So the drug trial remain the first thing, and the patients with the underlying restrictive pulmonary disease or the COPD should be cautioned over bronchospasm while on the beta blocker theory. Caution should be used to amiodarone in patients with the decreased pulmonary reserve and the fibrotic lung disease after COVID-19. During aerosolizing procedures such as intubation or the tracheoesophageal cardiogram, or the healthcare providers should be done appropriately up to level 2 or the level 3 precaution. And the cardiac computed tomography may be considered as an alternative imaging modality for evaluation of the thrombus prior to do an desperate cardioversion if patient is actively infected with the COVID-19. So given the high risks of the thrombotic complications in the COVID-19, early initiation of the selected group, irrespective of the high D-dimer, should be considered as a case-to-case basis. The indications and the duration of the anticoagulation is still unclear at that time, so we have to be judged on our clinical and case-to-case scenario. So management of the cardiac arrhythmias in patients with or without COVID-19 infection, as we have presumed that this patient is male suffering from postural orthostatic tachycardia syndrome. This is a combination of the adrenergic failure along with the cardiac ailments. So we need to have much time to point this patient at least 5 to 6 months that he is suffering indeed from this postural orthostatic tachycardia syndrome. To pinpoint or to stabilize marking him as a POST, we need to do some tests as a basic, and one of among is the tilt-table testing. And the patient with COVID-19 evidence of myocardial injury and inflammation should therefore should be forbidden from any kind of competitive sport or any hard activity to say or the aerobic exercise until 3 to 6 months following infection. And any kind of investigation which in necessity to the interventional should be held at least 45 to 2 more days to 2 months if possible, and all cardiac markers of the injury should be settled down before to draw it conclusion. And the management of the cardiac arrhythmias when it comes to the inappropriate sinus tachycardia in the general population, other etiologies sinus tachycardia must be excluded. So it is a diagnosis of the exclusion rather than diagnosis of conclusion. And the outpatient halter or event monitor may be helpful to say that only it is a matter of SA node dysfunction rather than whole pathway of the arrhythmia is involved. And beta blockers may be considered, and we have tried with it. And it is unclear whether the hip bedding may be useful in this scenario. So the management of the cardiac arrhythmias in patients with or without COVID-19 infections or other SPTs also the same. Anticoagulation is generally not indicated unless atrial fibrillation is also present, and which is not alone. And the catheter ablation may be considered, but with the high precautions of the level 2 or level 3, and along with all previous like a cardiac CT to exclude that any kind of thrombus is there. And outpatient halter or event monitor may be helpful for this diagnosis. And what about atrioventricular block? The same pacemaker placement for the complete heart block, symptomatic bradycardia, and the high DPAV block with the high precautions. There is plenty of very little scope wait for the drugs because already the injured myocytes may fail with the drug trial. And the necessity of the secondary prevention of the ICD is unclear, and the evidence of the COVID-19 and the ventricular arrhythmias may have no evidence of structural heart disease, and the acute infection may be considered a reversible precipitate. So we need to be patient with high alert. And in patients who do not undergo catheter ablation, the risk of concurrent arrhythmias after resolution of COVID-19 is still not known to us. We are not in a position to conclude. But what observation says that the onset of the new therapeutics or the COVID-19 further questions are raised as to how or impact is management of the arrhythmia. And studies are needed to investigate the association between the vaccination status and the risk of COVID-19 related cardiac arrhythmia. Future research is needed to determine whether vaccination may be protective to the cardiac injury development, cardiac arrhythmia per se, or which patients would benefit from the most. Similarly, the monoclonal antibody treatment, which is gaining much, and daily it is coming, be it tocilizumab or itolizumab, and everything coming day by day, we really in an unclear field that whether they have a significant effect on the cardiac myocytes or the cardiac conduction system, because we are blocking only single or 1 or 2 interleukins and also paving the ways of the other interleukins to lead the myocardial injury, at least theoretically. So I need much more time to conclude in these things. Finally, with the subsequent waves of the COVID-19 ongoing in the country, little is known to how this reinfection, a second course of infection, or affect previously affected individuals, what will be the course. The exact cardiac complications which may accompany with this second COVID-19 infections are yet to happen. So I cannot conclude from my slides myself, and I leave here for further discussion. Thank you.